So three, one. We are live now. We can start with the session.
Good evening and welcome to MGRx. As always, MGRx is not about reaching to the diagnosis, but it is about journey and how to proceed further. It is about understanding how the case evolved. And we have another interesting case lined up today that will challenge us to think beyond the obvious and explore the nuances in patient care. And we have an excellent team of experts. Let me just share my screen so that I can just give a brief introduction about all of them. So the title for today's talk is Appearances Are Glimpse of the Unseen. Presenter, as always, is Dr. Marine Thomas, who is working as an ILD fellow with me. And expert discussants, Professor Venerino, who is head of pulmonary medicine at GB Morgagni Hospital and head of department of thorax at USL Romana. We have Dr. Sara, who is a senior thoracic radiologist at the same place and specialist in advanced chest imaging. She is very uh, sought after for ILD radiology also. We also have Dr. Deepak Talwar, chairman of Metro Center for Respiratory Diseases. He has an extensive of more than 40 years with many awards and honor. Dr. Murli Mohan sir, who is senior consultant at Narayan Health, Bangalore, and he is expert experienced pulmonologist. Sarah, if you can mute yourself, yeah, thanks. And actively involved in academic teaching and postgraduate. Dr. Harjit Singh Dumra, who is a senior consultant pulmonology and critical care at KD Hospital, experienced clinician and advanced respiratory medicine. I think we have got Dr. Padmanabh Shinoy, who is a medical director and consultant rheumatologist at CARE and first Indian invited for plenary presentation at American College of Rheumatology for work in scleroderma. I believe we have got these are the clinical expert. We have got Dr. Ritu Kulshrestha who is going to join us from airport because she is so much interested in this particular session. She is one of the partner of planning this program. So that is why she must be joining for this. And she is a director and professor at Vallabh Chest Institute, Secretary Pulmonary Pathology Society of India. Let us start with the case now and over to you, Marin.
This is a gentleman, he's in his fifth decade, he's from south of India, who presented to us with a 25-day history of fever, which was intermittent, initially low grade with evening rise of temperature, and which progressed to high grade fever with chills over the preceding week. He received multiple courses of IV and oral antibiotics and was suggested ATT from elsewhere, so he came to us. He also complained of cough with scanty expectoration and streaky hemoptysis and history of weight loss of around 5 kg associated with loss of appetite. He had MDR-TB 2 years ago. His gene expert was rifampicin resistant indeterminate. He was a treatment defaulter. He took ATT for 7 months and he stopped it on his own. He's a smoker, 20 pack years, no comorbidities. On examination, he was conscious, oriented, hemodynamically stable. He was febrile, temperature of 101 degree Fahrenheit, saturating at 97% on room air. Systemic examinations were all unremarkable. Yeah. This is the X-ray that was done for him on day 1 of admission, where we can see left upper zone and right mid zone, lower zone opacities. And lab workup, again done on day 1, was within the normal limit. ESR and CRP were elevated 86 and 106 respectively. Sputum study was sent, which were all normal. No problems identified. 2D echo was normal again, EF of 60%. Urine examination did not reveal any RBCs or CAS. USG abdomen was within normal limits. No organomegaly, no free fluid.
Yeah, and Sarah, are you there? I will just share the screen. for
Yes.
yeah. So let me stop sharing from here and I'll share the screen from other side for CT scan. So yeah, so can you see my screen now, right?
Not yet.
Yes.
Yeah.
Okay. Okay. Yes.
Okay.
Now, yes.
Yeah, so this is the CT scan taken at the time of admission and I'm scrolling it. Yeah.
So here we can see a huge cavitary lesion and a consolidation in the left upper lobe, area, some paraseptal emphysema, a focal nodular consolidation.
Okay, here my doubt will be when you are saying about paraseptal emphysema, can all other than left upper lobe, the right lower lobe, can it be infected bulla or something? We lost you, Sarah, or
Okay.
you? Yeah,
Okay, ecco, now, sorry, maybe the connection is not.
yeah.
Okay, now you have a cavitary lesion in the right lower lobe with air fluid level, and
Do you think
more
all
nodular.
these two lesions, upper lobe and sorry, left upper lobe and right lower lobe, are of the same nature?
Yes, yes, are in different stage maybe, because do you have the mediastinal window?
Yeah.
Just to an idea of the necrotic component. Yeah, they are necrotic. In the left upper lobe, there is a component of necrosis in the central area, and due to the fact that the right lesion is bigger, developed a component of air fluid, but they are in the same range of disease. And the smaller lesion are nodular without a necrotic component, yes.
Yeah.
They are mostly peripheral, and they show angiogram sign, I think, because if we give a look to the smaller lesion, they have a connection to the vessel. So we can...
Which lesion you are talking?
In the
Sarah?
left lower lobe, yes, that one. If we go back to the parenchymal
Lung window. Okay.
yeah, the lung window. Yes, look, they have a small vessel arriving to the lesion. So yeah,
Okay.
and
So
the
what
most
does it
important
suggest? What
yeah.
does it suggest if the vessel is going into the lesion?
Yeah, it's something raising from vascularity. So in
Can it be
differential
septic emboli, multiple septic emboli?
can be if they were not in these sides, because the septic emboli are smaller with a thinner wall, because being septic, they arrive to the necrosis quickly. So they are smaller and they don't have this component of consolidation like in the right lower lobe. So they can arise from vascularity, like, for example, vasculitis. I have in mind, for example, EGA, EGP, or lymphoproliferative disorder with vascular spread, for example, large B-cell lymphoma or LIG. I guess we are in this kind of differential diagnosis.
Okay, your first diagnosis vasculitis, then you think of MALT or BALT kind of lymphoma. And
yeah.
And infection, any chance?
Infection, yeah, some chronic, yes, but low with the, we can consider, I don't know, maybe if I don't know if histoplasmosis can give this kind of, yes,
histoplasmosis, okay.
Yes.
How about tuberculosis?
Tuberculosis is unusual because we don't have any adenopathy in the mediastinum. So I would be surprised. Just this small lymph node in subcarinal. Yeah.
Okay. And how about kidney and liver? You feel it's okay, right?
Yeah, can be, liver is a little bit large, but spleen is okay, and kidney, yes, normal in appearance, yes.
Okay. Yeah. So with this clinical features and with this CT scan, anybody wants to ask anything? Sarah will be here for a very small time. That's why.
So, Meren, do we have any previous X-rays from the last MDR TB issues?
No, sir, we don't have any records of this MDR-TB episode. No treatment.
You
But
said
I had seen Harjit Singh that X-rays, and that were not quite different from the current X-rays. Okay.
So how long back was that?
2 years before he was started on TB medicine, gene expert positive, MDR was indeterminate, and this is around 2014. So just gene expert came. So the interpretation of report of indeterminate of rifampicin resistance was considered as rifampicin resistant present, and that time category 2 was existing. Patient was started on category 2. 7 months he received.
So what you're saying is 2014 X-ray and the present X-ray were nearly identical.
Almost same site, same lesions. I did not see any difference. Yeah.
Okay.
So I
And
think
what was the strength of the AFB smear? Was it 1+ trace? Because
AB smear, I don't remember. I think they did expert or AB was not positive.
Resistant indeterminate, many times the load, bacillus load is very low.
Yeah.
If you got an RR indeterminate, what was the smear? Trace? Was the MTB?
I think smear was not positive. This was, I believe, only expert positive and RR indeterminate. And
But strongly positive, trace.
trace, I think it will be trace. Yeah.
Okay.
I think it's a false report. This does not look like tuberculosis at all. Clinico-radiological correlation is not existing out here. If 2 years you are saying the size remains the same, that is something which is totally like not a malignant again, not a malignant. 2 years is a very long time. And finally it comes to what? What exotic infections have been discussed about fungus, this, that, and of course vasculitis. All those are the only possibilities. Will vasculitis remain like this for such a long time without going changes? Yes, we have seen that many a times they just stick around there with cavitations. But I think the first thing important would be that which Sarah has brought in. Sarah, how comfortable we are in saying both the lesions are the same disease. Like obviously either both are same disease or there are two diseases in this patient. So to accept two diseases will not be easy. So first to consider that it is one disease is very important.
Yeah.
Yeah. But the fact that there is component of necrosis in the smaller lesion and and air fluid in the bigger may induce to think that we are in the same spectrum of disease.
I think that was an amazing observation which you passed on, that there is a necrosis there. So it is just the same story in this place. So you shouldn't think of two diseases, rather think of same disease in different phases, where one has already undergone a necrosis and emptying, the other one is in the process of going on. And it's a very slowly ongoing process. So indolent kind of a nature of the disease, which can be in fungal infections as well as in some vasculitis. Malignancies, which malignancy can produce this kind of cavitations, which are not rapidly progressing, numbers are not increasing. Obviously, that is a very big question mark, that are we at all even looking at malignancy as an option or not? So if you have to give, what are the options you will give for this kind of scenario?
Lymphomatoid granulomatosis and large B-cell lymphoma. I have in my mind these two lesions. So lymphoproliferative disorder with a kind of possible indolent. No, large B-cell is not indolent, but can show slowly increase in size.
Can it be aspergillus? Aspergillus can present
Aspergillus,
like
yeah.
this, aspergillus, because in India we don't get histo like this kind of presentation. This is
Okay, yeah.
unusual for histo, but aspergillus can present like this. We have seen that, so that's another one. I do not know. Murli is there. Murli, what else you? I do not know. Asmita is definitely giving very strong hints to keep us away from coming to the puzzle.
So I'm going to, disagree slightly. It's always nice to have an alternate viewpoint. This man's a smoker. He's got a high ESR. He's been losing weight. I agree with you completely that the gene expert is probably false positive. He has lost weight. He's got significant emphysema. We are seeing paraseptal emphysema on both sides. The lesions itself, some of them look spiculated. One has a pleural tag. The same vessel, same lesion, which has the feeding vessel sign, has a pleural tag, all of which are pointing me towards malignancy. The point against malignancy, as you rightly say, is the slow rate of progression. But that we're completely possibly being misled by Dr. Asmita's comparison of an X-ray with a CT scan, which is bound to miss a lot if you try and compare an X-ray with a CT scan.
Yes.
So I would still say malignancy would be fairly high on my list, just given the possibility in a smoker with COPD. I completely agree with fungal infection, especially some kind of indolent aspergillus. The problem being not seeing any invasion of the surrounding tissue. There's no halo sign that we are seeing, and that's a little worrying for me. But hardly any lymph nodes. What lymph nodes we have are showing calcification. There's also a calcified granuloma in the liver. So could he be just having tuberculomas, which have now turned malignant and started to cavitate inside? I don't know, but I would still keep, I completely agree on the lymphomas with Sarah, but I would like to keep a bronchial CA, an indolent bronchial carcinoma in the background. I've seen patients biopsy proven twice with a squamous cell carcinoma going on over 8 to 10 years. An elderly lady was doing beautifully for 10 years with one thing which has reached a size of about 10 centimeters in diameter. No metastases anywhere. So along with everything Sarah has said, I would like to still keep a malignancy in mind.
So
Venerino, Professor
or one
Venerino.
malignancy.
I
Two
think that's
malignancy or one?
Two malignancy or one?
I think that Sarah's made the good suggestion. I also, in my mind, one hypothesis could be granulomatosis, lymphomatoid granulomatosis. In that case, we should have. Do you have a lymphopenia in the peripheral blood, or the blood tests are completely normal?
I will just share, sir. Lymphocytes were 11%. I can say we had lymphopenia, right?
We have lymphopenia. Is it correct?
Yeah. We have.
Because League is associated usually with CD4 lymphopenia, and we don't have data, of course, regarding EBV serology, I guess.
So EBV serology. So you mean to say that if lymphopenia is there, that goes against EBV?
No, I think that lymphomatoid granulomatosis is associated usually with lymphopenia in the peripheral blood, CD4 lymphopenia. Yeah.
So Professor Paletti, there's no real lymphopenia. He has a high white cell count and he's got neutrophilia.
Yeah,
So
yes, I know
the
that.
lymphocytes are lower.
Yeah.
Shana, you want to add up something or? Yes, sir, Professor.
Yeah. More or less discussed, Asmita. More or less, the chance of vasculitis staying indolent for such a long time, it can happen in a indolent vaginus we have seen, but with such high ESR and CRP, usually the PR3 will be positive. If PR3 is positive, most of the time they have renal involvement. So very difficult to say 2 years just staying like that. GPA is the only thing which comes to my mind with such huge cavity. EGPA looks very unlikely because he doesn't have any asthma and eosinophilia is not there. So GPA staying indolent for such a long with PR3, very, very rare. We have seen, I'm not telling we have not seen, we have seen, but looks less likely.
Sure.
Other thing, I would like to keep a broader differential diagnosis.
Professor Venerino, you were saying something. Please.
No, just nothing to add. I agree with the discussion we have
Yeah.
had so far. Yeah.
Sure.
Just,
So,
just I
yeah,
have seen that there is a bronchus entering into the larger nodules in the lower right lobe. So I think bronchoscopy here should be very helpful for the final diagnosis.
sure.
So,
Yes,
Asmita,
yes, sir.
one question that does the house believe in the word which we used to talk about a lot? When you see so much of this thing and it comes like necrotizing sarcoid granulomatosis. That was one term which used to be used quite often, and
Yes.
then now only of sometimes this is used when you get nothing but you get all the granulomas. You couldn't find anything. There is necrosis there, and you find necrosis with sarcoid granulomas, and you are left with nothing but to label it necrotizing sarcoid granulomatosis.
Sarah, if you are still there, is this particular picture fits with what Talwar sir is describing? Because we had seen such cases of necrotizing sarcoid granulomatosis, most confusing with TB,
Hmm.
So
if
I
she
think
is there.
necrotizing granulomatosis in sarcoid is a histopathological diagnosis. It's not a radiology of cavitation. So
Sure.
necrosis is in the granuloma on biopsy. It is not
Okay.
that you'll see a huge cavity in a sarcoid granuloma, which is visible like a sort of a large round mass.
Yeah, that's why I'm asking that whether radiology, because sir is thinking in a futuristic way, whether if it
My
will.
bet is that a high-grade fever is usually not seen with squamous cell carcinoma. That
Okay.
can be seen with lymphoma. So my bet is more with lymphoma if we
Hmm.
are thinking of a malignancy.
Okay.
High-grade fever is unheard of with most of the TB things and fungal infection. If there is no immunocompromising condition, I would be reluctant, even though the patient might have underlying COPD, he might be colonized with fungus, but you didn't give us any history of inhaled steroids. So again, fungal infection without immunocompromised host, neither a diabetic, neither a pre-existing post-cox fibrocavitary disease, neither immune suppression with any drugs. So that makes it a little lower down the list. Vasculitis is my second differential, but lymphoma followed by vasculitis.
Sure. I think, Marin, you can go ahead and we will discuss again.
Okay, ma'am. So the issues that we had at hand at this point was a patient with persistent febrile illness and increased inflammatory markers and bilateral cavitatory pulmonary lesions.
Yeah.
So what is the most appropriate differential for this presentation? What we were thinking of, our first leading differential was vasculitis, closely followed by probably infection like tuberculosis or a bacterial or fungal infection, and neoplasm as well, squamous cell or a cavitating mets. So to follow up with our leading differential, we did an autoimmune workup and found out that ANA-IF was borderline positive, speckled, and C-ANCA was also weakly positive. Rest of the autoimmune workup were all negative, including anti-PR3. This patient, despite empirical antibiotics, he was having persistent daily fever spike of around 101 to 102 degrees Celsius all the time, all the days when he was admitted with us from 6th to 18th August.
Yeah, so that was the most dreading thing when you go for rounds and every day morning you expect that some miracle will happen and fever will go, but unfortunately that was not happening. And this is like you can see how the real life situation is that we discuss here when the case is already solved, but when reality comes in a picture that you are going for rounds every day morning, patient is expecting, the only reason patient got admitted with us was to control the fever. And this I have taken picture from the file itself because this was the most challenging thing for us at that time, that how to take care of that fever part. I have put the entire duration, so it was not like we did not do anything, but we were doing something, nothing was working overall. So what investigation should be done next? I think we will, Professor Venedino has told that bronchoscopy should be done, and I will not waste time in discussing that aspect. We did bronchoscopy, and these are the pictures. I would help you that these are the normal bronchoscopy. This was the nasal mucosa of the patient. So if you have to do, we actually did BAL and this, but this was something worrisome, and I called ENT specialist because we used to work next to next, and during that time, ENT specialist came to my OPD, and because I was seeing this, they told that okay, go ahead and do biopsy. So that is how. So Marine, you can go ahead. This is.
So we sent BAL for this patient. BAL microbiological workup is all negative. Cytology was also negative for malignant cells. The nasal
Yeah.
area was abated, but the incidentally noted nasal lesion, we biopsied it as well. But the nasal lesion further raised a suspicion for vasculitis.
So
But
I think Ritu madam is there, and Ritu madam can comment on this particular biopsy, and then maybe Professor Venedino also if she's
I'll
there.
ask you, Asmita, why was
Yes.
a CT guided biopsy not considered in this lesion?
So, sir, what happened now that we felt that if we will go ahead with bronchoscopy, we will get cultures also, because most of the times our CT people take samples for biopsy and then some complication happens and then the culture specimen does not come in a picture. When I was seeing a cavity, I felt that the best way to, if it was TB, because it was like defaulter, that time people were labeling people as a defaulted for TB medicine, high likely of TB. So I felt the thing which is creating a cavity inside the lung, I should grow at least one TB bacteria from that. So I decided that I should take lavage from that. Now, as we can see, the bronchoscopy was totally normal. So,
Was anticipated. See,
yeah,
if you were very lucky that you were
you got
seeing
this.
nasal cavity,
Yeah.
and you, in fact, if any of the fellows would have been doing a bronchoscopy, they wouldn't have even looked at the nasal cavity. They would have just gone unless and until it started bleeding. If it would have bled, then only they would have raised the alarm that there is something wrong. Otherwise, they would have missed it completely.
Yeah.
So my only question was that I think your center does not perform biopsy
No,
tissue.
we do, sir. This is just starting of the case. Don't worry. So we did CT guided biopsy later on, but let us see what happens here.
Why
Uh,
did you do a transbronchial at that time?
I felt transbronchial. It was quite peripheral, and I was quite happy seeing this, Harjit. To be honest, now I was, because my first diagnosis was vasculitis, and I saw something in the nose. You can see my excitement that wow, I don't have to do transbronchial. I can
You
get
can
away by.
still have dual pathology, one in the nose and one in the lung, which will not
Yeah,
matter
I did
later
not
on.
think that time. I was like really happy to, I don't know whether it is the correct word, but I was happy to see something in the nose which I can access so easily without doing any complication to my patient, and look at the bronchoscopy pictures, like clear, right? So I felt okay, maybe I will get away with this biopsy, and that is why we did.
So did you add histoplasmosis at this point to your diagnosis?
So fungal culture was sent, I believe, but it came negative, sir.
Hmm.
No,
You may not see
histoplasmosis was
anything.
not my diagnosis.
You may
It
not
was
see
not.
anything on culture really, which again says, a CT guided biopsy, you'll
Would
have to
have been
speak
better.
with the
Yeah.
radiologist and say, please send it for culture,
Yeah.
or send one of your residents and say, make sure they put it in saline and take it across for culture.
Sure, sir. So, Ritu madam, you want to comment something on this biopsy?
Asmita, Bal galactomannan was sent.
No, I don't think we were doing that.
2014,
Yeah, I don't
who
think
was
we were
doing it?
doing it.
Who was doing bile galactomannan at that time?
So it
Yeah,
was always being done. It was not something which we
yeah,
have
yeah.
done.
But I did not send it. That will be
So,
the better
Or
answer.
aspergillus will
Actually,
never turn out
I-
to be positive. Galactomannan is the only signal.
Harjeet, considering the non-specificity of galactomannan in this patient, I wouldn't have even sent it because it would have come high unnecessarily without only on the basis of galactomannan to treat
Never,
this patient.
never.
Would
But
have
your
even-
differential was aspergillus. You said aspergillus. You should.
Correct, but not on galactomannan in any case. IgG
Yes, yes.
aspergillus
Yeah,
would have
yeah.
been
But
better.
I would have taken a biopsy also in that.
ठीक है.
Then
I agree.
if you have
I
taken a
agree.
biopsy, then why do galactomannan?
Because biopsy might turn out to be negative.
So if it comes out to be negative on galactomannan, you'll treat this patient. I don't think so. Clinico-radiologically, you'll be able to treat. You'll
My
need
differential
definitely a
was not
biopsy proof.
fungus, sir. It was yours.
I'm
Okay.
saying that I wouldn't have done the galactomannan at all.
I think the people have changed, but the same spirit is there, and I'm so happy about it. Let us bring Ritu madam here. Madam, do you think anything we have to move on?
Yeah. So in this biopsy, we can see that there is a polymorphous infiltrate. It has it's got nuclear debris. It's got neutrophils. It's got these dark pinkish cytoplasmic cells, which I believe are eosinophils. And in addition, in the center here, you can see just to the left of the center, you can see something which looks like a Reed-Sternberg-like cell to me. So they are binucleated. Just below. Yeah, this one is a histiocyte, and just below that there are two cells which are looking like Reed-Sternberg-like cells. Yes, just to the right of that. Just to the right, and they have got large nucleoli which are eosinophilic. They've got some amount of amphiphilic cytoplasm. So something which I could not explain why I'm seeing this.
Sure.
So I'm seeing some histiocytic proliferation. I'm seeing, as rightly labeled, I'm seeing mixed inflammation which is present on this image.
Okay.
So we go to the next slide. Yeah.
I think no. This is only one slide for this patient.
Okay.
Professor
Okay.
Venderino, you also agree with this, or you want to add upon?
Yeah, I think it's not specific.
Non-specific. Okay. Okay, now to panel. This is for panel. So I believe that all of you will agree for repeat biopsy, right? Rather than starting empirical immunosuppression. With this report, Shenoy, will you have convinced that this is vasculitis?
No way.
No way. Okay.
No way.
So that is what. So we also were not convinced that it is vasculitis, and we felt that this patient needs repeat biopsy. So we had high clinical suspicion of vasculitis.
Ask Dr. Ritu something.
Yes, please ask.
She's muted. Yes, you said, ma'am, Reed-Sternberg cells. So, like, how convincing are that for lymphoma in this specimen?
So keeping this polymorphous population in mind, I would actually keep a B cell lymphoma or a lymphomatoid kind of granulomatosis in my differential at this stage.
Would you ask for an immunohistochemistry on this biopsy?
I would. At least a CD3, CD20 for LIG and a CD15 or a CD30 for Hodgkin's lymphoma. Because I'm seeing a polymorphous infiltrate as of now.
So what happened is my pathologist did not comment anything other than inflammatory cells. They suggested repeat biopsy. Now the doubt was whether you will go ahead with the repeat biopsy from the nose lesion which I was seeing earlier, or you would go for CT guided biopsy of the lung.
Obviously, lung, at this time, it has to be lung. There is no doubt about it.
Okay.
And I think what Ritu is saying, because you do more tests to confirm it is there or not, it's wasting time actually. Every day you are suffering with this patient, running fever, and going on the same thing again and again and not coming to diagnosis is delaying your process actually. You have spent almost 10 days struggling with this patient. And in fact, you found something which was not a symptom at all. You are trying to hit. So next time, rather than going and exploring further on the same, there's no point. Go to directly to the lung.
Can I?
My question is, could be primary Hodgkin lymphoma in the lung?
Primary. It
Because,
can be now.
Yeah, because there are cases or reports.
Low-grade lymphoma.
Hodgkin, describing just Hodgkin, primary Hodgkin lymphoma in the lung, appearing as cavitated lesions. And the kind of fever is quite unusual, I think.
Yes.
Only thing is that there are multiple and both lungs. So
yeah. But there are some reports. I remember papers in the 80s by Tom Colby and others with primary. The first author was Samuel using primary Hodgkin lymphoma in the lung with multiple cavitated nodules. So could be a possibility. Why not? But anyway, I think definitely we need a larger biopsy.
Yep. So somebody in the beginning, I also asked Sarah, and I think Harjit also asked that, are you sure that the both lesions are of the same? I think Talwar sir asked. So that was the same thought process of mine also. I felt that left upper lobe was quite solid and right lower lobe was cavitary. So I specifically asked my radiologist that I want biopsy from both. Sorry, but we did that. It is not like
No,
routine
it's
thing that,
fine. It's
yeah,
fine because you were
yeah,
running against the time. You were
yeah.
running against the time. Look at the fever chart of the patient. I'm pretty sure it is very frustrating
Yeah.
to go to the bedside of the patient and look at the sullen face that my fever is not going. What are you doing?
Yeah.
And these are
And
low risk biopsies. So I think certainly worth doing both.
Yeah,
yes.
no
Yeah.
problem. Correct.
Marin, you can go ahead now. Yeah.
So we went ahead and did a CT guided biopsy, both from the right lower lobe and left upper lobe lesion. The aspirate from the left upper lobe lesion was thick whitish purulent material.
From the upper lobe, not from the
No,
lower.
no, no, no. It was from lower lobe, sir. The pus kind of
Yeah,
thing was
because that is what
whitish.
I'm saying.
Yeah,
The
yeah.
whitish material will from the lower lobe.
Lower lobe, right lower lobe. Left
Yeah.
upper lobe was solid. And yes, my radiologist was kind enough to send for cultures.
And the nice thing there is you can see the beautiful air fluid level. It is shifted exactly with the prone position. So
Correct.
Yeah. That was good observation. Yes. Marin.
We did a microbiological workup. AFB smear was negative again. AFB culture was awaited at the time. And the histopathology.
Ritu madam.
So here now in this smear, we can see that it is amorphous, it is pink, it is involving the entire area where we are seeing. So given the morphology, there are no viable cells or nuclear debris which can be seen in this. So given the amorphous and the pink nature of this necrotic material, it has been labeled as a caseating granulomatous inflammation. There's one more section here. Yes. If you see here, now this is a more viable portion where there are histiocytes here. These histiocytes, I tried to see, are, the nucleus of the histiocytes is S-shaped or slipper shaped. They're vesicular in appearance. There is a moderate to abundant amount of eosinophilic cytoplasm. And in addition, now you see on the periphery on this right side, you can see there are eosinophils which are there in admixed in this histiocytic inflammation. So while it's very tempting to call it as a granuloma with caseous necrosis, the eosinophils which are coming up here are the ones which are leading us towards an alternative diagnosis of whether we are dealing now with eosinophilic granulomatosis with polyangiitis, EGPA, or whether we are dealing now with whether we are dealing with just simply a fungal kind of a in infection, where I would like to see a periodic acid shift or Gomori silver methylamine stain. Or the third differential, which on this basis we like to rule out, would be that of a Langerhans cell histiocytosis. But of course, the necrosis would be against. The large amount of necrosis would go against it. So with this biopsy, we'd be considering a fungal versus EGPA kind of a diagnosis on pathology.
So, ma'am,
Okay.
can I ask you one thing that, we know that granulomatous enteritis itself also can have eosinophils there. So, is it like GPA ruled out completely in this?
No, not on this. I would not be able to rule out EGPA on this. I would be able to rule out a Wegener's definitely on this, because Wegener's is more neutrophilic, vasculitis, and it is showing basophilic necrosis. So here we are seeing a caseous eosinophilic necrosis, and we are seeing eosinophils which are present, but we are not seeing the typical Langerhans cell morphology of the nucleated nuclear lobes, which would show us point on morphological basis towards the Langerhans cell. So two differentials here. After we've ruled out fungal for sure, we would consider the most likely would be eosinophilic granulomatosis with polyangiitis. or short straws?
EGPA is one which you are like bringing as the strongest possibility here. So, like 15% don't have asthma. So, is this patient not asthmatic, Asmita?
Never.
Okay, so
Rather
you want to
COPD.
keep it into that 15% which do not have asthma at the time of presentation, which is a possibility. But why is GPA not the first reason given here? Because clinico-radiologically it fits into GPA. Is that right, Murli and Harjeet and Dr. Poleti?
I think that this, in my opinion, the histology is completely non-specific, not helpful. It is inflammatory, but we do not have the typical GPA aspect, that is geographic necrosis, and we don't have other elements suggesting a strong elements suggesting a specific diagnosis. Did you perform special stains for microorganisms
So
in the
they did, sir, AFP and GMS stain, but that was negative.
negative?
And
So
my pathologist signed off it as a caseating granulomatous inflammation to rule out tuberculosis. My radiologist specifically mentioned whitish pus kind of material aspirated from well, like when they were doing biopsy, rather they were getting a pus kind of material. And I am getting caseating granulomatous inflammation in those slides. So what would you do next now? All those who are agreeing for vasculitis, that was my first diagnosis. But I got pus. With
Yes, of
this,
course. See, you have got first primarily because that what the pathologist is giving you actually like tuberculosis. They are
yeah,
pushing you to the tuberculosis.
yes.
Patient has already taken ATT. Patient is not demonstrating gene expert. Patient is not demonstrating AFB smear. Everything is negative on that patient. So if you think that the previous ATT has done everything negative and it is still going on, then why are the lesions there as it is? Why they have not gone even an inch
So
small?
the logic was patient was defaulted at 7 months. There is no guarantee that he would have taken the medicines also regularly. And lots of discussion happened about this point. And my only doubt was if it was like pus aspiration was something which I was not comfortable starting immunosuppressants with.
So, Asmita, Bal cytology was done, eosinophilia in the Bal.
No.
What about Merin, Bal gene expert you did not mention?
No, maybe that time it was not available in my hospital, or
So
I
sputum
also,
gene
yeah.
expert was done.
That was out. Oh, sputum gene expert. Bal gene expert का क्या हुआ? Marin, we did not send it, or
No, ma'am, it is not there.
it is not there. Yeah. Mhm.
Okay, so
But the
another thing is
question
when
is,
you biopsy a necrotic lesion, it is not infrequently that you will get pus. The trick is that your radiologist should always biopsy the wall. The moment you go inside the lesion, you are going to get pus, and pus can come in inflammatory disorders. It does not mean infective just because you picked up pus. There are lots
Okay.
of lesions where inflammation will cause pus and it will misguide you. So whenever I hit a CT guided biopsy in such lesions, I insist that if we can hit the wall, that is where the diagnosis is. The pus is usually necrotic. It doesn't give us the diagnosis. Even cultures are negative.
I think I fully agree with Harjeet that anything which is a necrotic tissue looks like a whitish and palish yellow kind of a thing is not a pus actually. It's just a dead material. And most of the times the pathologists look at it and they say that this is a caseous material, caseous material. The sound is made like that. So I don't think so we can go by that. But I think the end the question would come that can it still be tuberculosis or not? That is the one thing which will be there in the mind of everybody in view of incomplete history, everything else going on. But the only question is if the patient was defaulter, he was not taking treatment, everything was not doing good, then why didn't the disease increase? Why didn't it increase? Why it
Yeah.
didn't? So what a kind of beautiful immunity and mycobacterium tuberculosis was going on in this patient. Very hard to believe.
Yeah.
So I think this
Yeah.
biopsy which you showed, Asmita, was both the sides represented the
I
same
think
thing.
now retrospectively, I did not think that time, but I believe that one should be caseous necrosis should be from the liquid thing, and the other thing which showed those cells, histiocytes and all, must be from the left side, because that time I was I revisited the case. I have done this CPC with my pathologist also because I was not happy with him giving me caseating granulomatous inflammation. So he told this is what it is, and that is how. But that time also
Asmita,
I did not discuss. Yes, sir.
Asmita,
Yeah,
Shana here. There are three issues. One, to EGPA, so many oddities for EGPA. One, there is no eosinophilia, there is
there
no
is
asthma.
no
All these things
asthma.
are anti-MPO negative. And
Yep,
also cavitating lesions in EGPA are rare. It
extremely
won't
rare.
happen, but it can happen. It happens. So many oddities for a
Okay.
EGPA.
Okay.
So I think I will
How
add
about
it to
GPA?
Shinoy.
Shenoy,
Shinoy,
GPA?
I will add it to you this that eosinophilia peripheral is not seen in 50% of EGPA. We have just published the paper of 24 cases. Second important thing is ANCA is negative in 60%. It is only positive in 40%. So
Which,
only
sir,
thing
if you,
which
it would be great if you could send me the paper. Eosinophilia is
sure.
actually whatever rheumatological series they say it's 70 to 80% usually have. Whatever,
So
at
it's
some point
basically
before.
how we look at it and what is the eosinophilic
Mhm.
counts we are looking for. So
Yeah,
if 300
that's
is not considered significant, then it is
yes,
not
sir.
eosinophilia according to us.
Yes, 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 yes,
So that's
yes,
the
yes. That
point.
then,
Yeah.
yes.
But
So the problem
basic,
is,
when the patient doesn't have any other allergic history coming up, it will be very difficult to make EGPA diagnosis
GPA
in this
diagnosis.
patient.
This
so
is
that's the
Very
this.
difficult.
problem. When you have too
Yeah.
many of these things that may not be there, but at least you have to have a few of them coming up to make this diagnosis.
Yep. Yep.
One of the things that we often do is get a PET done, and that guides the radiologist in taking the biopsy from the active part of it, especially when you have a cavitating lesion. You can even do it blindly. You take it from the wall, as Harjeet said. Uh, uh, there was a biopsy taken from the right side also. Are you
Left
sure?
side also. Left side and right side, both, sir.
But what did you show us? You showed us from the left side only, or you've
No,
got
I
the right
showed you
side
two
first
pictures,
side?
na, sir? So this is right
So
No, no,
and
I'm
this is
talking
left.
about the histopathology from the right side.
So that is what I was saying, that I don't know which represents what. This is the
Ah.
images provided. So I was just imagining that maybe this is left side one and this is right side one.
So Murli, you said PET scan. I'm very happy. In 2016, if she would have done a PET scan, people will have killed her, saying that what a absolute misuse of PET scan it is. Even today, you and me cannot manage without a PET scan because we want exactly where it's the brightest area to be sampled by the radiologist. But still, when we talk on any podium in India, we are criticized that we are misusing the PET scans. People don't realize rather than having no diagnosis, it is always better to do a PET scan so that at least you get the right tissue, everything right. And then if you don't get, at least the chances are much less, much less. But I think India has to move forward with that because we have
Okay.
much cheaper PET scans as compared to the West.
Now all of you answer me. How many of you would have been comfortable starting immunosuppressants on this report?
No.
Harjit Singh?
So, see, Asmita, not for this report, but when you are spiking fever for 14 days and it is not, your procalcitonin was negative, I would start suspecting inflammation very long back. We've seen these patients spiking fever right, left, and center, and because we are taught that fever is infection,
Okay,
we
which drug?
fake it.
Immunosuppressant, which drug?
So I would have given him a shot of 40 milligrams salmeterol much earlier. But that would be for the fever, not for the pathology. And if his fever would respond the next day with no worsening in CRPs and PCTs, I would be tempted to explore the inflammatory option. I would have not given him any immunosuppressant without giving him steroids. So once I give 40, if he shows some response in symptoms, I would be tempted to give him 125, maybe 250, but not immunosuppression till I'm reasonably sure that it's an inflammatory process.
Sure.
So Ritu,
So,
Dr. Ritu is there or she is gone?
So she's there.
I'm here. I'm
Yeah.
here.
Yeah, okay.
Yes.
Are you sure that we are not looking at lymphoma?
Exactly.
Are you sure we are
That's
not
the
missing lymphoma? Because we miss lymphomas.
real trick question. When I saw that single read Sternberg cell, it was something I wasn't expecting, because after seeing the lung biopsy, I was pretty much sure I'm looking at a histiocytic lesion, and I'm looking at one which has also got eosinophils. So I was looking at a lesion which had two components, histiocytic and eosinophils. and necrosis along with that. But when I saw the nasal biopsy, that was very stumping because here was a polymorphous infiltrate with a very nicely formed one single reed Sternberg cell. So
Sure.
I am really now wondering whether we are dealing with two pathologies or not.
Okay, I will just specifically ask Professor Venedino, you would have started immunosuppressant in this patient.
Now, honestly speaking, our approach should be a little bit different because we would have cryobiopsy, and in
Okay.
this case, you can have cryobiopsy in both lungs in the same procedures.
Okay.
Using
But this is some 10 years before. I think it was 2017. I'm not sure.
okay,
Even cryo was
17, okay.
available. Yeah.
No, okay, yeah. You're in 2017.
Not
Yeah.
debating the size or the representation of the tissue. The CT guided biopsy is equally good. Like you've got chunk of tissue. It's not the biopsy specimen which is up at a problem. It is the interpretation which is an issue right now.
Now the problem is that with cryobiopsy, you are using a radiolabus, and you can explore if you have sampling the necrotic tissue or the viable tissue, because with EBUS you can recognize the viable part of the tissue. So with this approach, I understood that in that period was not available, but with this approach you can select exactly the
That's what
viable
I think
part.
Dr. Murli was saying, that if you do a PET scan, you know that you're putting your needle not into a dead tissue and you are going into a live tissue there. So that was the idea of PET scan I think he brought in.
Now, but I am sure that PET scan here is positive, but with the radiolabus, you know, it is,
Sure.
yes, I think it depends.
Asmita,
Yes.
Asmita, I want to pick variants for others. I was just checking all rheumatologists, double checking again. Eosinophilia is around 90 to 92%. I don't know, Dr. Talwar was telling around 60% will not have eosinophilia. That's what I heard.
So
If I was
most
wrong.
of the time now, Shenoy, why sir is saying like that is all our asthma patients are already on steroids.
No,
So
that is fine. That's fine. That's fine. With steroids, eosinophils melt.
yeah,
But
that
as
is
a
why.
untreated EGPA, it shouldn't, because a lot of people are hearing this. I just want to clear the air.
No.
That
So it
untreated
will be one
EGPA.
incident that then when they present, they may not have
Yeah,
eosinophilia. That is what.
yeah. No, that is fine. That is fine. But that is treated eosinophil. Once somebody
Yes,
puts on steroids, the specialist is not on steroids, no. So
No,
lack
he
of
was talking
eosinophilia.
about the series of asthma, severe asthma, in which EGPA was
Yeah,
the
that's,
end diagnosis. So maybe
yeah,
there
yeah,
is some
they,
misunderstanding.
yeah. Okay.
Also a problem with bias. Unless we see eosinophilia, we don't tend to diagnose EGP. That's part of
Yeah.
That
Yeah,
was
Yes,
the
yes,
idea
yes.
to bring this paper for our
Yes,
doctors,
yes.
basically, that
Okay.
don't miss it thinking that you need ANCA, you need eosinophilia, and you need multi-system disorder, which
Yes,
does not happen because it happens at different points of time
Yeah.
where you do not know where they are going. Sometimes to gastroenterologist, sometimes to cardiologist, sometimes to neurologist,
Yes.
and sometimes to dermatologist, and you keep missing the link. I think that was
But basically, sir was trying to say that in severe asthma, the series which he is talking about, I have read that paper, Shenoy. So the paper was about severe asthma patient in which we give everything and still patient is not improving, and retrospectively they diagnosed that it was EGPA. So basically,
yes.
patient will be multiple exposure of steroids. So
Yeah,
just because
very
of
clear.
one pinpointing, that is why. So he
Yes,
that
very
paper I
clear,
have
very
read.
clear.
Yeah. Okay.
Yeah, clear. So, but
And
there will be asthma there, no?
will you start
But there
it?
will
Yeah,
be asthma.
asthma was there. Yeah. Will you start steroids or any other immunosuppressant in the current case?
Now, because you have given everything else, probably yes, we'll start.
Okay,
That's
you
what
will
Dr.
start.
Harjit also said.
Okay,
But I will keep a watch on of something else going on. Sure.
sure.
So
Mullimon,
the
sir.
problem will be, I think, Asmita, whether to give steroids with ATT or without ATT.
Yeah. So I did not start steroids. I don't give blanket treatment. So I give
True.
only one treatment. So
what I would do is get a second opinion on the slides and ask for special stains.
Absolutely. Absolutely. 100%. It was like against the wall. You have done everything, you are not getting it, then obviously the biopsy slides have to be reviewed.
okay. I think Marin, you can go ahead.
So in this setting of caseating granulomatous inflammation, thick pus-like aspirate, and a history of tuberculosis with treatment default, we initiated the patient on ATT despite the initial suspicion of vasculitis. This case dates back to 2017 when category 2 ATT regimen was recommended under RNTCP, and hence we started the patient on HRZES regimen on the basis of his weight.
So this was the fever chart which we showed till 18th of August, and then we started TB medicine.
So 2 days after starting ATT, the patient showed marked clinical response. He became afebrile for the first time in 45 days and was subsequently discharged 3 days later.
Yeah, surprise, right? Even I
Fantastic.
I was like
See?
shocked. I was shocked to see this because in my mind, my diagnosis was still vasculitis, and this is the result of medicine. So what can we do?
Yes.
I
And
can
But it's
only
not
say which
vasculitis.
anti-tubercular treatment leads to disappearance of fever by the next day. I have never seen it, so I will still not accept the diagnosis.
absolutely, this is too quick
But
response.
that is why I brought the images of the fever chart, sir. Nobody will believe. They will say you are making it up, sir. I'm not making it up. This is what happened.
No, we believe you completely. The thing is, this does not suggest TB.
Yes.
You know, 2 days you have such a good response. Never seen it in TB.
But sir,
The antibiotics will
you
work on any
see,
infection.
you see 6th August to 18th August, every antibiotic we tried, no response. 19th of August, we start TB medicine. Patient becomes afebrile next day.
Did he grow
No,
anything in the culture?
Actually,
Yeah.
I think Dr. Murli is very right that if somebody's fever goes in next day, you
Yeah.
exclude tuberculosis from that. It cannot be
very
tuberculosis.
true.
No.
Very true.
Actually, I found out that pyrazinamide can have that kind of effect. Seriously, I was also shocked that how can this happen? This is not true, but it happened, and I have to accept that within 3 days we were able to discharge the patient, and we thought everything is fine, but it was not.
Okay, so another but was there.
Yeah, yeah, Marin.
We observed the patient for 3 days after ATT and discharged him and asked him to come back to our clinic after 1 month.
Yep, that is what we expected, but
You obviously come much earlier.
So he came back to us 10 days later. Now he was complaining of loss of appetite, further loss of weight of 4 kgs. From 55, he went to 51. And now he has new onset hearing loss.
Oh,
So in fact,
interesting.
Smita, if this
Yes.
would have happened in our unit, I can bet you that some resident in the night duty gave hydrocortisone to the patient.
No. Patient did not receive hydrocortisone. No, it won't happen. It won't happen in my unit, sir, because they are really scared that nothing will be given just like that. But this is what happened. And in OPD, when patient told me loss of appetite, I told, okay, ATT induced jaundice. And I thought that decreased hearing, unnecessary streptomycin was given. So streptomycin caused this problem. These were my two possibilities. Anyway, we investigated.
PR3? Did you repeat?
Now she is telling a ear is getting involved.
Yes,
Yeah.
that's what we now it is
From
interesting.
the nose, it has gone to the ear, and
Yeah.
then she's still making us look at the lungs.
Yes, Mary.
So we repeated the labs for him. Labs were all normal. ESR and CRP were still elevated. In fact, ESR was higher than before, 86 before, 104 now. Repeat X-ray, which showed some new lesions in the chest as well.
Other side also, left lower lobe has also got new lesions. Yeah,
those
they've got
became
new
more
lesions,
prevalent.
multiple new lesions, and now they have become empty actually.
Yeah, they became empty. Now, this was my doubt that if the lesion from solid becomes empty, is it response or is it worsening?
Well, it's probably necrotic and he's coughed it out or brought it out in some way or it's got absorbed.
Yep.
And maybe that's the reason why his fever subsided, huh? All this pent up secretions, dead tissue had come out.
Maybe. But it was that right side did not change, sir. Left side became from solid to cavity. I was like, what's happening? Anyway, we did ENT evaluation. Yes, Naren.
We got an ENT evaluation for him for his hearing loss. They did an audiometry and tuning fork test and found out that it was conductive hearing loss. Nasal endoscopy was also done, and there were friable masses over both eustachian tube orifices. Given the atypical trajectory of the patient, we repeated a tissue biopsy and sampled the eustachian tube lesion.
So my ENT specialist, because I called him, he also called me and told that, Asmita, this doesn't look like your streptomycin-induced neuropathy. This looks more sinister than that. And then I told him that my first diagnosis was vasculitis. So he told we planned repeat admission, or maybe on OPD basis or whatever way. We tried to do repeat biopsy, and this is the repeat biopsy. And Ritu madam.
Yeah,
Thank
so
you.
yeah, so in this biopsy, again, we can see that the components are polymorphous. There is histiocytes. There are good number of these bright pink cells, which are the eosinophils. And they're saying necrosis. In this section, I can't say necrosis. I can't see necrosis here. So again, it goes back to whether these histiocytes here are benign or are they atypical, because some of them have got that eosinophilic, nucleolus, which can be seen, a prominent eosinophilic nucleolus, which can be seen in such a polymorphous population. I'm now really worried because this is a repeat. This looks like a repeat of the nasal biopsy which we have seen.
So, but on this report, this AFP and pass was negative, and again we discussed with pathologist, and somehow he told that this kind of mixed inflammation can happen in vasculitis.
So in none of the biopsy specimens, any vessel was identified, Asmita.
Yeah, so that is when we did CPC. So because this particular case, now I retrospectively going to my pathologist was, why did he give me caseating granulomatous inflammation in the first place? Because caseating name itself suggests tuberculosis, and even though my first diagnosis was vasculitis, I could not start proper medicines because of that. So he revisited slides, and these are the sections which he gave, but I faintly remembered that he told me that there was a vasculitis kind of picture. I'm not sure whether he told granulomatous vasculitis, but he showed me a sections in which there was a vascular infiltration of these cells. The vessel was invaded by all these cells. Something like that he showed me in one section. I'm not sure whether Ritu madam, you are able to see any vessels in this particular sections.
No, ma'am. I can't. I can only see the
None of
polymorphous
the
infiltrate. Yeah,
none of the
no
biopsy, na?
vessel. None of
None
the
of the biopsy.
biopsies.
But he could
Yeah.
see it, because when I got a diagnosis, and when I went and, like, not fought, but I actually went and told him that you gave me wrong diagnosis and that is why it happened. Then he showed me again the slides, and when he saw it again, he told me that, yeah, there are some, because now we know the diagnosis, maybe we can see the things which we want to see. I don't know. Most of the times that is what prompts
I
this happen.
totally agree. If I were to see so much of abundant caseous necrosis in our setting, where most of our second cases are caseating tuberculosis granulomatosis,
Yeah.
I would happily sign it out. But now I'm worried after seeing this case, I will also have to now rethink before signing out caseous necrosis. Yes.
Yeah, but I think story is not yet over. Marin, you can go ahead.
So we pulsed this patient with 1 gram for 3 days, and we continued ATT till his AFB culture turned out to be negative. There was good response to treatment. His constitutional symptoms improved, inflammatory markers reduced, and we discharged him on oral prednisolone 1 milligram per kg. So this is the X-ray that was taken after steroid pulse. The patient received 3 cycles of cyclophosphamide along with tapering dose of corticosteroid. Despite treatment, the inflammatory markers remained elevated and there was only suboptimal clinical response. This was the X-ray and the labs while 1 month after starting cyclophosphamide therapy. ESR was 80, CRP of 50.5, persistent lesions in the chest.
Shenoy, what would you have done? We can't
PR3 is
hear
also
you.
negative, no?
Yeah.
Repeat PR3 is. No, sorry. Can you hear me?
Yeah,
Did
yeah.
you repeat
I did not repeat PR3. I did not.
PR3?
No,
Did
no,
you
no.
repeat a PR3?
No, I
Yeah.
did not repeat
Okay.
it. Yeah.
Yeah. See, somebody, his fever subsided, right? if fever
Fever
subsided,
subsided,
but his
yes.
inflammatory markers are high. See, so for his for GPA that we have seen, these inflammatory markers take time to. Somebody who is PR3 negative, see if you see vigilance GPA, you will have definite. What is that? If so many lesions, usually PR3 is positive about 90%, 80-90%, unless it's a limited disease. This disease you
Limited.
expect the PR3 to be positive, but yeah, EGPA, I will be very again. I told you, without a treatment naive EGPA, without eosinophilia negative, without asthma, with cavities, all extremely so.
So patient
I would
received
probably continue cyclophosphamide because we
cyclophosphamide
have
and steroids. Would you continue the same or hike up, because radiological clearance
repeat it.
also was
I think yeah, there. So I would probably repeat a CT after the completion of cyclophosphamide. The UVAS protocol will be the best one. UVAS is 2 weekly 3 doses and 3 weekly 2 more doses. I don't know which
Yeah.
regimen you have followed. Cyclophosphamide.
Yeah, that
In
whatever
GPA,
the
you
3
required a
weeks,
slightly higher
3
dose.
weeks wala. Yeah.
And yeah, 3 weeks wala. So 2 weekly 3 doses and 3 weekly 3 doses up to 2 to 3 months. Probably it's a time that we repeat a CT scan and see. CT scan, yeah.
So we did not repeat CT, but we repeated X-ray, and this was the thing.
Yeah, because so what happens is if the inflammation is not subsiding, what we do as a protocol is we do a PET to see whether there is some other inflammatory focus which is there which we have not seen. That is another thing what we do. Yeah.
Post steroids, Asmita, did his hearing come back?
Yeah, hearing
Yeah, very
improved.
true.
Hearing improved.
Put in just a torch to see whether the nasal lesions had decreased.
I think we did ENT consultation and they told patient is improving. So
No,
he
lesions
was
and
improving.
ear lesions both improved with steroid?
Improved. Everything improved. We did
Okay.
repeat ENT consultation also.
Nose
And
improved, ear
yeah.
improved, lung improved partially.
Yeah.
I would go with an IHC on the first specimen before considering rituximab because it is an anti-CD20 and even lymphomas would respond to rituximab. So my problem would be that once you consider failure to cyclophosphamide and you are jacking up to rituximab, you would need to rule out lymphoma before you do that.
No,
But
Dr. Asmita,
how
whether
rituximab will help if cyclophosphamide is not working?
So
Ritux is slower
sometimes
acting.
no, the algorithm is failure to cyclophosphamide. You should step up to rituximab.
no, first of all, whether she has failed on rituximab depends on what the disease activity is. Looking at inflammatory markers alone, you cannot say that we cannot say that she has failed on cyclophosphamide. He has failed on cyclophosphamide. If his lesions are better, he's symptomatically better, and he's sometimes we have seen it takes 6 to 8 months for the CRP to normalize sometimes. So based on this alone, we cannot say he has failed on cyclophosphamide.
No, I was saying that in case we consider
Yes. Yeah,
and we are
definite.
planning to
Totally agree.
rituximab, we must rule out lymphoma first.
100%, 130%. That's what I was telling. We have to keep the other diagnosis in mind rather than just thinking of vasculitis alone, because so many oddities are there for vasculitis. Although I agree with Dr. Asmita because she has been pushed to wall, she has tried everything else. She has given cyclophosphamide. If he is not responding, probably we need to rethink.
Yeah. Anyway, that time we did this. Marin?
Yes.
So we transitioned to rituximab-based immunosuppression. His inflammatory markers came down. We could successfully taper him off corticosteroids, and there was radiological improvement as well. This is the X-ray that was taken 7 cycles after rituximab, the first X-ray compared to after rituximab X-ray.
So 7 cycles were given at what interval? Like monthly?
So this was taken in 2021, sir.
Okay, so like 6 monthly, 7 cycles have gone, 3.5 years.
Yeah. In between, COVID also came. He got admitted for COVID also, but he survived COVID. So I think that's it. That was the case. And any reflections you people want to add?
Do
Or
you have any final diagnosis now to give this?
yeah, I think we treated it as a granulomatosis with polyangiitis.
Asmita, you still have the biopsy specimens lying around somewhere?
I'm not sure why you want to reassess.
I want immunohistochemistry.
I think
maintenance rituximab.
Who is laughing?
I can actually do it, Dr. Asmita. You just send it to me and I'll just run it.
I will check. I'll
But
check.
it won't make any difference now. But I think the message which goes is that it can be frequently missed. And the very important thing is the clinical situation. And actually, if she would have not treated with TB medicine, she would have been always in the quandary that whether she should have given ATT also or not. Every time the same haunting would have come back. Why the TB was not treated? Why the TB was not treated? So only thing is that in a kind of setup where she is working and she has a support and everything, she could carry on with this kind of this thing. But as Harjeet said very rightly, and also Murli, that for us the only thing was send the slides for second opinion, third opinion somewhere else, because it looks like GPA, but it is not coming out to be GPA. But otherwise, for you, I think it was a momentous decision which you have taken, and showing after like so many years that finally the Retux did work. Actually, I think a lot of people would have hesitant even given in Retux, because if Cyclo doesn't give a response, Retux in addition to Cyclo might give, but I do not know. I think
I think
it's
Mithun was the one who took it was combined decision. And when was the last 2024 also we had visit, na? Marin?
Yeah,
Patient is
ma'am.
he is
Yeah.
regular follow-up. He's doing well. Actually, thankfully, he's doing well. And I would like to add upon something that this is 2017. I was not HOD of the department. I never wanted to start TB medicines. I was forced to start. And when the person who forced me to start, I told him that after starting steroid, his things improved. Then the answer was steroid has got camouflage effect. If you give steroids, everything improves. Doesn't mean that it worked. So that is the answer I would give to Harjit also, that if you start steroids, patient improves. Does not mean that you reach to your point.
Asmita, we know that. In some
So
patients,
I
we
have a
do
question
it.
for
All
Dr.
this-
Shenoy and everyone else. You know, you're worried about TB still. Cyclophosphamide or rituximab upfront? Because
Rituximab any day. Rituximab any day. Rituximab any day. Because rituximab is an anti-B cell therapy. We know that T cells are more important for tuberculosis. Rituximab is any day safer option than cyclophosphamide.
Padmanabh, just if I may,
Yeah, please.
how many patients who fail cyclophosphamide with GPA end up responding to Ritux? Like, is it a significant amount?
20-30%. 20-30%.
So not too many fail cyclophosphamide.
Yeah. Not too many. 20-30%. That would be the number. And there are patients who failed on both, and we have to give combination of cyclophosphamide rituximab. We have 5 or 6 patients whom we give combination. So it happens. It's not that it doesn't happen. Yeah.
so
But
Retux you give the same. Sorry.
sorry, please, sir.
Fail cyclo and then you give Ritux. What is the duration of maintenance Ritux?
There are definitely there are main lot of trials are there. Main and 2, 3. What they suggest is 6 monthly will be best. And there is a regimen based on decide based on anti-PR3 levels and the CD19 B cell repopulation. There are 2-3 regimens which are available, but
How long?
if you don't want
Once every 6
minimum
months maintenance, but how long? How many years?
minimum 3 to 4 years. 4 years minimum.
Okay.
48
Not
months.
if it's 3 years, but generally we are giving 5 years. We are only stopping.
Yeah, 5. Yeah.
Yeah.
But yeah.
But I'm sure that even in our setup, if this would have happened, we would have combined both cyclophosphamide and rituximab in this patient.
Yeah.
Because generally Ritux doesn't give that good response immediately, and you will lose if you stop cyclophosphamide. So generally we do both of them. But of course, it's a very
Cost
difficult
was the
situation.
problem.
It's a very
Yeah.
difficult question.
That time cost was
Otherwise,
very
also
high.
there are
Yeah.
big problems here. Caseation necrosis by one pathologist to be countered by another pathologist is not going to be easy. It's not going to be easy.
Yeah.
Everyone will be doing ditto because they don't want to deviate from if the word caseation has been used. It's very difficult. Very difficult.
Yeah, Marine, we can.
Yeah. So this
Great.
case I'll
Yes.
This is something we always say, isn't it? Whenever we have an ILD or one of these strange cases, the answer often lies outside the lung, not in the lung.
Correct.
Yeah. Yes, Marine.
This case highlighted the importance of reassessing a working diagnosis when the clinical course deviates from expectation. Extrapulmonary manifestation, particularly ENT involvement, provided the crucial clue that redirected the diagnostic pathway. Cavitatory lung disease is a pattern and it's not a diagnosis, and radiology achieves its greatest value when interpreted within broader clinical context. So all caseous granulomas are not TB, and repeat negative microbiological investigations were as important as the biopsy findings themselves. So histology only supports a diagnosis, it does not make one. And response to treatment is diagnostic data. Revisit the diagnosis when the pieces stop fitting. In cavitating lung disease with upper airway involvement, always think beyond TB.
I think it is great case. So wonderful, I must say, Smita. It would have been totally different when somebody would have seen it in 2024, because as Murli said, I think extrapulmonary, most important is a PET scan, which identifies that which will be the site outside and more likely to get you the diagnosis. So maybe people are more, intelligent after the PET scans have come into picture. But that's what Murli and I would have done in 2017 even.
But here, na sir, I would like to highlight that it was not that we missed something. Actually,
No,
that is why we did a biopsy from both the sides.
you did everything actually. You did
Yeah, so
not, it's
here,
not question of a missing. It is a question of that, you are in an institute where you can actually go back, forth, up, down, left, right, center. In our setups, we really need to get to the bottom of
yeah,
it
in the
as soon
one
as
go
possible.
itself. Yeah, one go
As much
itself.
as soon as possible. So two-sided biopsies, everything possible you have done already actually. I
Yeah,
think this
because
case highlights beautifully how the patient sticking to you is also very important. This patient could have run away because it's
yeah,
enough now. Enough is enough. How long you want me to suffer? I think that's the quality basically. And we learn from such cases, because if this patient would have been diagnosed somewhere else, something else, nobody would have known actually what has happened to the patient. That's the story. But this is beautiful lesson which you have given, and a very, very beautiful case. But I have seen in life only two things trouble you most when you don't get the diagnosis. Either it is a lymphoma or it is a vasculitis.
yeah.
So the other interesting thing I must remind you is right in the beginning, Dr. Sarah Pikuchi said, vascular thing leading into it, think of a vascular problem. Right in the beginning, that was her first diagnosis. So
I
radiology
think
does
she's a
help.
wonderful radiologist
Yeah,
actually. She
she's
saw
very good.
she saw the necrosis, which even I had not seen that necrosis actually. I was still wondering that is Asmita showing two different diseases today to us?
I also thought like that the left upper lobe is so solid, and right lower lobe is cavity. So that is why I insisted. Look, that this is one thing is patient did not go from here because this is Amrita, and when they come here, most of the times they don't have any other choice.
Correct.
So
That's it.
we,
That's it.
yeah,
Other lesson I
That's
think is
that's
important. Sorry, Deepa, go ahead.
I think that's the most important thing, that they stick around because they know that this is the tertiary care center.
yeah.
If they don't get answer here, there will be no
They
answer
won't get.
anywhere
So
else.
we were better off because of that. And the second thing is like to convince. I don't know how I convinced the radiologists, but they used to listen to me. They did biopsy from both the
Who
sides.
doesn't listen to you? Tell me. So the other point I wanted to make is it's so important to have the original DICOM images. You can play around with the settings, otherwise you'll miss so much. And then the importance of a contrast CT is also very important.
Yeah. So DICOM images, sir, I think because as sir told, now the setup where I am working is the beauty of the case is that is what I was telling Ritu madam that this case happened in 2017. And Marin has visited the files, right? Marin, you went to MRD and she had seen the files. Though the pictures of fever chart I took that time itself because I was the person who was them against TB medicine, even TB medicines because of the crazy thing. I was still fighting with pathologists that this cannot be. This was vasculitis. How can you give me this diagnosis? But because of the discussion, she actually read my notes that because I don't have any choice, I have written that the vasculitis diagnosis is suspected but not possible in the background of caseating granulomatous inflammation, pus aspirate, and persistent fever to start TB medicine. So it was even that time also she came back and told that I have written some notes like that because I believe I was not very much convinced of starting TB medicine. But what happened is fever subsided. Now that
is the other lesson. TB will not respond in 2 days.
Yeah.
It's not TB.
So that means our teaching is correct. Our teaching is correct. Age-old teaching is correct. If it responds within 2 days, think of something else. Don't think of TB at all.
But now I'm worried, Dr. Talwar and Dr. Asmita, Dr. Murli, that if after seeing so much of abundant caseous necrosis, which we just have a look at it and then we just sign it off. So now we have to be really, even while signing such abundant caseation, also we have to be careful. I think it's a big takeaway.
So this was I was finding the cause, how the fever went. So I would have checked everything. So steroid, everything's are checked, but I was shocked. And the person who was against TB medicine, I have to stand before like 4 or 5 people who were from the beginning suggesting TB medicine. So they don't look, and patient also happy. So I was like, how can it be possible? But it happened.
So I think the dictums don't change, but yes, minds need to change.
Yeah, so it was the reason is the presentation of this case is, these are the cases now which I won't forget, sir, because this all cases where I have to stood against the tide, or you have to go against the tide for proving yourself or proving your diagnosis, and finally it happened, and that it was vasculitis. From the beginning, I thought it is vasculitis. I also thought whatever you people thought, but unfortunately, still with that, we have to start TB medicines, and
I think Murli will agree with me. Murli, if you are standing in the court of law that you have given a diagnosis of caseating necrosis in a biopsy, which has been done twice, and you have not given 82 to the patient, which previously had a gene expert positive, it would have been a tough case for people to decide.
Absolutely.
It would have been really a tough case.
Yeah.
At that time, what you did was 100% correct, that you gave it till the time culture came negative and then you stopped it. That now I have 100% proof that culture is negative. I don't want to go on with it.
Yes.
Yeah, so this case was actually granulomatosis with polyangiitis masquerading as tuberculosis. TB masquerading as many things happens, but this was one of the rare, and the F title was Appearances Are Only Glimpse of Unseen. And with that, I would like to end. Thank you.
Thank you, Asmita, for teaching us so much today.
No, we all learned, but it was a great case, I believe, from the beginning.
Absolutely.
Excellent case. Thank you so much.
Thank you.
Ulimon sir, we got one another person who has so many books behind his back, and that was Professor Venerino.
Good.
Good observation again.
Yeah.
So there are two people who read actually.
Baki, all of us are on mobile. Okay.
And I've reached home. Thank you. I've reached home in
Thank you.
Mumbai. Bye-bye.
Thank you.
Thank you. Bye.
Thank you. Bye. Bye.
Bye, everyone.
Bye.